Welcome back to the Intersect. Today we have two very special guests for you. The first one is Dr. Emma. I'm sorry, I got to start this over. That was not very good.
So much better.
There we go. Now we all feel better, right? Mary failed.
We did that. We got the first mulligan, so now it's all good.
We're good to go. Good to go.
Okay. Welcome to the Intersect. Today we have two very special guests for you. Dr. Emily oh my gosh, I just said McDonald's and now I can't say McElrath.
Oh my gosh.
Okay.
You got it, girl.
It's a lot.
My maiden name is Guggenheimer, so I don't have an excuse. Okay.
You have no excuse then.
I know. Welcome back to the Intersect. Today we have two very special guests. Dr. Emily McElrath is a native New Orleanian and the owner of Dynamix Physical Therapy and Wellness, which is a PT clinic that specializes in orthopedics and pelvic floor physical therapy. Emily is a former runner turned CrossFit enthusiast who has a passion for helping people optimize function. She uses her background in both orthopedics and pelvic health to provide comprehensive whole body care to her patients. Welcome, Dr. Emily.
Thank you. I'm glad to be here. Thank you for having us.
Dr. Jenny Porter is a physical therapist specializing in pelvic floor therapy for men. That's right. You heard me right. I said men, women, and children with bladder, bowel, sexual, and pain dysfunctions. She also specializes in physical therapy for pregnancy and postpartum care. She and her husband, Mason, have 3 daughters, ages 4, 2, and 4 months, that keep them very active outside of work. Welcome, Dr. Jenny.
Thank you.
We're so excited to talk about this topic because obviously I think physical therapy in general is a pretty commonly understood term, but many people don't know what pelvic floor physical therapy is or how valuable it is. And I think it's exploded really in recent past. All of a sudden, I think you're hearing a lot more of it, which is good, and why we wanted to do this episode. And just to put this into perspective, I was a licensed PTA, a physical therapist assistant for 6 years, and I know little to nothing about pelvic floor physical therapy. So we all have a lot to learn, right? So can you explain what is pelvic floor physical therapy and how does it relate to women's health?
Yeah, I think that's a great question. I think starting by explaining what the pelvic floor is oftentimes helpful because I think a lot of people don't even really fully understand what that is. So I have my little model here, if you guys can see. Okay, so the pelvic floor is actually a musculoskeletal system. I think a lot of people think of it as a sexual organ, which it is, it can be, but it's also a musculoskeletal system. So the muscles of the pelvic floor are basically muscles that attach to the bony part of your pelvis. So the pubic symphysis, the tailbone, and all that. And these muscles not only help support the pelvic and abdominal organs, but they also play a role in bowel function, bladder function, sexual function. And so in pelvic PT, much like you would for orthopedic PT, we are kind of looking at those muscles. We're making sure that they're able to contract properly, that they're able to relax properly. We're making sure that the bony joints around the pelvic floor, so the SI joint, the hips, the low back, all of that is working and functioning properly as it should. And we can even assess the external genitalia to make sure that everything looks healthy and normal there. You know, a lot of times just looking at the external genitalia can kind of give us a clue as to what might be going on internally and things like that. And so we look for signs of potential hormonal changes, muscular imbalances, scar tissue that patients might have either from abdominal surgeries, from endometriosis or cesarean. And we can look at scars from childbirth. So like perineal scarring from childbirth, and look at to see how that might be affecting the function of the muscles in the area.
So interesting. So you mentioned external genitalia.
Yeah.
And then you talked about looking like on the inside or evaluating. Can you
Yeah.
explain a little bit more specifically what that is and what
Yeah.
would you describe that as internal work?
Yeah. So we
Okay.
describe that as internal work. So typically what you'll find when you have an evaluation with a pelvic floor PT, and Jenny can go into more detail with this for like men and children, but in general, we're looking at what does the external tissue look like? So do they have restrictions in their abdominal tissue? Are there scars to the external genitalia? So perineal scarring, for example, from childbirth. Sometimes when women go through menopause, or if there's significant hormonal change, you can see some like dryness or atrophy to the vulvar tissue. So we'll do kind of a visual assessment of the external genitalia first. And then what we basically do after that, if the patient is comfortable with it, is we'll do what's called an internal assessment. Now, that's going to differ a lot from what an OBGYN does. We don't have stirrups in our clinic. We're not using a speculum. We're literally just using one gloved finger. And basically we start by kind of gently touching or palpating the external tissues to see if there's any pain response just from that. And then if the patient is okay with it, if they're comfortable with it, if they are going to, seems that they will tolerate it well with no pain, we'll do an internal assessment where we'll basically, if this is my vaginal opening, we'll take one gloved finger and we'll place it just inside the vaginal opening. And we'll have the patient kind of do a Kegel and squeeze our finger to see if the muscles are able to contract properly. And then we'll have them relax. And then we'll have them almost kind of bear down, like what you would do if you're having a bowel movement or if you're having a baby, to see if those muscles can load the other way appropriately. And then we'll kind of gently feel on different areas of the muscle to see if we feel any trigger points or muscle tension, much like other muscles in the body. Your pelvic floor muscles can become tense, or they can get trigger points that can become painful. This can lead to pain with intercourse, pain with pelvic exam, pain with use of feminine hygiene products. It can even lead to like kind of strange, diffuse, like lower abdominal pain or hip pain or low back pain. And so we're kind of looking for, does the patient have any of those trigger points? Are we sort of able to elicit the pain that they were feeling before? Can we kind of find the cause of the pain and things like that? And then we're basically using everything that we found in that assessment to develop a personalized treatment plan to address whatever impairments that we found throughout our assessment.
And so that would be an example of a vaginal internal exam that can also be conducted rectally if that's necessary. So that would be if you're trying to emphasize the backside of the pelvic floor, something near the tailbone or the bowel, or men, that's the only way to do an internal assessment is by a rectal exam. But internal examination is just one component of what a pelvic floor physical therapist can offer. It definitely doesn't encompass everything we do, but it's definitely the most personal and intimate, but it gives us some really, really great information.
Yeah. And people always, so to give a little background, I was in orthopedics for years before I switched over to pelvic health. And it took me being Jenny's patient for me to kind of realize like, oh, okay, like there's something to this. And when Jenny first recommended doing an assessment on me, I was like, oh God, no, like you're my friend. I don't want you looking at my vagina. That's no. And so we understand how intimate it is and how intimidating it is. And so I think also the fact that like when we learn, we have to practice on one another. That's how we get certified in pelvic health stuff. So I think we can be sensitive to how sensitive a patient will likely be, and kind of understand the intimacy of the appointment.
That is awesome. And I love that y'all, you just kind of came out with addressing that like, hey guys, this is what this is. We understand that like we are getting up in your business and it's going to feel weird, but, I loved your explanation of everything. I'm like a little bit of an anatomy and physiology nerd. Those were my favorite subjects when I was in school. So like I was eating that up.
That's awesome.
But yeah, it's really amazing. Like this is such a burgeoning field right now. And we're learning so much about how necessary this is and how overlooked it is. Like I was at my OBGYN's office recently and, we were talking about, I was going to get a referral for a pelvic floor PT. And she was like, are you having any issues? And like, that segued into this conversation about,
she had a patient who thought it was totally normal to laugh and pee a little bit. And she was like, actually, no, that's not normal.
Not a thing.
Yeah. So I think that this is such a huge opportunity for people to realize, and this is so endemic to fertility awareness as a whole, that it is about holistic health, and it's about understanding your whole body and how it all works together, and how if you have a problem in one area, there could be an issue that you would never have thought about otherwise. So I'm loving this. I'm eating it up. So let's kind of dive into some more specifics here. Like, I know women are listening to this and they're like, okay, if I'm going to let you like stick a finger in my vagina, it's got to be for a reason. Or men, to have a rectal exam, like it's got to be for a reason. But let's talk about women. So women experience, all sorts of changes throughout their reproductive life. Some, which they may not be aware of. I know, endometriosis is one of those things that might not be diagnosed readily, or it takes years. So in your practice, you address the physical effects of hormonal birth control, which some people might be like, excuse me, what? So we're going to tee you up for that. Endometriosis, infertility, vaginismus, painful intercourse, postpartum, and more. So we'd like you to talk about how your practice addresses these issues and what signs or symptoms might a woman experience that would indicate that pelvic floor PT might be a good option for her. So let's go back through the ones that I just mentioned, and I will just name them off. And then if you can just give like a brief little explanation. So let's start with hormonal birth control.
Yeah, Jenny and I are going to tag team this one, if that's all right.
Perfect. So let's start with hormonal birth control. Go.
Okay. So hormonal birth control is interesting because, as you know, it's widely prescribed and used by women of all ages for various different reasons, right? And so there's a lot of use of birth control, but I don't really feel like there's a lot of discussion on some of the side effects of birth control and how it can sort of negatively affect your actual anatomical tissues. A lot of the side effects that are mentioned are more like weight gain or this or that. But actually, we see a lot of patients who have been on hormonal birth control for years. And sometimes these are young women. I mean, in their 20s, mid 20s or late 20s, early 30s. And they're having almost menopausal type changes to their vulvar tissue. So the tissue are dry, they are frail, they are atrophied. And ultimately, this can compound some of the problems they may have already been having, right? So all of those changes to the vulvar tissue can cause tissue fissuring, which is like little bitty, almost like paper cut tears in the tissue. So that becomes painful when you try to use a tampon, when you try to wipe. It can lead to painful intercourse because you can have frictional discomfort due to the dryness and the atrophy of the tissue. And so we look at that a lot, and we kind of talk with the patient about other options they have. Certainly, we're not going to discourage patients one way or the other. We are not physicians. We can't prescribe medication, but we just like to educate patients as to other options that they have out there. And if it is a certain situation where they have to stay on hormonal birth control, we kind of review things with them that they can be doing to kind of help improve some of those changes. So daily moisturizing of the tissue is huge, right? And so there are a lot of products out there now, like there's this stuff called V-Magic, which I actually have a little sample tube of, I can get in a second, but it's made by Medicine Mama Apothecary, and it's a little all-natural compound that's got things like shea butter and vitamin E oil and things like that you can put on your vulvar tissues daily that will actually help rehydrate those tissues so there's not as much pain. There are also things that a physician could prescribe to somebody who's having menopausal type changes, which are topical estrogen or other sort of compounds like DHEA that will kind of re-plump up those tissues so that they're not having as much pain and they're not having as much tissue breakdown. And I was gonna, I don't know if you're okay with this, but I was gonna segue that into painful intercourse because a lot of patients that we see that are having painful intercourse do have tissue dryness, and hormonal birth control is not the only cause of tissue dryness. It's just a really prevalent one that we see a lot that doesn't really get discussed much. So we always like to bring that up with our patients. Another thing, surprisingly enough, and I don't know, maybe you can attest to this right now. Jenny's got a baby. Her youngest is, a few months old. So nursing hormones can actually reduce your body's estrogen, and that can cause dryness to the vulvar tissues as well. So in referencing back our assessment that we're doing, those are all the things that we're looking at. And so when we see a patient that has vulvar dryness or atrophy, we're like, are you nursing? Are you on hormonal birth control? We're kind of trying to like check the boxes to see what might be causing that. And a lot of them are coming to us for other things, right? They're coming for urinary incontinence or something like that. And then we get to the part in our evaluation when we say, okay, well, do you have painful intercourse? And sometimes I'll say, well, no. And I'll say, okay, so is it tolerable or is it enjoyable? And they're like, well, it's not really painful, but it's also not really enjoyable. And now that you mention it, it does kind of hurt sometimes. So I think a lot of patients don't even really realize necessarily, they might have had pain with intercourse for so long that they are not really recognizing that is sort of an issue. So I want to start with painful intercourse by saying intercourse should never be painful. If intercourse is painful, that is a sign that something needs to be addressed with your pelvic floor or either your external genitalia in terms of like dryness or frailty or things like that. So if you're having pain with intercourse, that is not normal, and you should not have to live in pain. I highly recommend seeing a pelvic PT if you are having pain with intercourse. There are tons of reasons, and Jenny, I'm sure she's going to kind of touch on some of these reasons after, because there's some of the diagnoses that you brought up. But I mean, pain with intercourse can be from anything from vaginal dryness from birth control or nursing to endometriosis to interstitial cystitis. Another condition that we're going to talk about in a minute, which is vaginismus, which is basically just that overactivity or that really severe tension of the muscles of the pelvic floor, that can cause a lot of pain. And then, I feel like for pain with intercourse and vaginismus and really all of these conditions, it's really important to take a multifactorial, multi-clinician approach to these kind of conditions, because a lot of them don't have just one necessary cause, right? Take a woman who's had pain with intercourse for a decade, and now she's got also vaginismus because every time she's had sex, it's been painful. And so she's guarded and those muscles have stayed tight. And now it's this vicious cycle, right? And then also there's an emotional component to it. So, you might be wanting to get pregnant with your spouse, and that's a big stressor for you because you have pain with intercourse and you don't necessarily want to have intercourse, but you'd really like to have a baby. And so then there's like this stress component to it, like, what's wrong? Why can't I have sex? I'm supposed to be able to have sex with my spouse and I can't. And so we really like kind of covering all those bases in terms of, we do the aspect that we can, and then we like collaborating with other healthcare professionals so that we can get the patient kind of this holistic whole body approach, so that they're not, we're not just addressing one little thing and then we're leaving this other stuff. So we really want the patient to have the best possible outcomes. And so we prefer to collaborate with other clinicians who specialize in the components of those diagnoses that we don't necessarily address.
Yeah, I want to take just a minute, and I'm so grateful for how much you're highlighting pain during sex is not normal. And I think that we have so normalized that for women. It's like, just get over it. It's just your lot in life. No,
or have a glass of wine.
Absolutely not. And I love what you just highlighting with vaginismus, that it literally does become this psychosomatic. Vaginismus is trauma. It's literally trauma. If you have vaginismus, and like you said, it can become to the point where women have such a negative association with sex that their body literally stores that information. And so pelvic floor physical therapy can help on the physical side, but there's a psychological side that needs to be addressed. So I love that it's collaborative, because it is about the mindset. Why are you afraid of sex? Where did this negative view comes from? And on my platform, one of the things that I find that is just heartbreaking is that women literally are told, you owe your husband sex. This is what, and that is literally processed as trauma. And so her body responds. And then, this is the problem that comes out. So I just wanted to highlight that a little further and just say thank you for doing that, because women, if sex hurts, stop. You do not. Well, and sometimes it can be as simple as you just didn't do enough foreplay and you need some more lube. I talk to women and they're like, they don't know that the vaginal canal widens and lengthens with foreplay. And I'm like, it's literally a physiological necessity.
Yes.
Not an option.
Yeah. So to give you like a little anatomy, like geek out moment here.
Give it to me.
The superficial layer of the pelvic floor, which is like all of this right here, that layer is responsible for orgasm, arousal, lubrication to our tissues. But in order for all of that to happen, those muscles have to be stimulated and they have to start working and they have to start sort of pumping. And that doesn't just happen just because, right? And so that is where foreplay is huge, because foreplay is essentially stimulating those muscles of the superficial layer of the pelvic floor so that our body can do what God made it to do, basically is get good blood flow to the area, get natural lubrication to the area, so that intercourse is more enjoyable. I think, what is it, like 20 or 30 minutes on average?
Mhm.
Like it takes like 20 to 30 minutes on average of like foreplay for a woman to get to the point where her tissues are physically ready for intercourse. So
and those are the muscles like in the labia. So in the lips,
Mhm.
they go and feed into the clitoris. So those are the muscles we're talking about. And it doesn't take direct stimulation of those tissues to necessarily have the physiological effect of it. But you do have to have intimacy and touch, any erogenous area in the body to have that kind of stimulation. But those are the muscles that we're talking about here.
Yeah.
And for those of y'all wondering who are listening, what she's pointing to, you can also watch this on YouTube. She has this beautiful structure that she's pointing to and showing us all these body parts. So if you want to see what she's talking about, go find our YouTube channel so you can watch this. But also, I just want to point out the distinction too between dealing with pain and pushing through it, and a woman just not even recognizing or knowing herself enough to admit that she's having pain. Like those could be two different things. And the latter kind of goes along with this whole narrative that we talk about in general of women's health. That's something I experienced with cramps, right? I did know I had that pain, but a lot of the stuff that we deal with, we just put off because it's like, it's fine. No, it's fine. I'm like, this is totally normal what I'm experiencing. And so just wanted to highlight that as well, that we're worth it. We are worth going the extra mile to be healed. So we don't have to experience that. Our quality of life is important enough.
Yeah.
And it's worth the conversation. Like, we're really good at internalizing all these things and keeping it to ourselves, which is how I think we got to the point where we're at, where all this is considered normal. It might be common, but this isn't normal because we're really good at not talking about this. So thank you for the opportunity on this platform to do that.
And like, that's the thing that I always tell patients, and I think Jenny can touch on this too when she talks about vaginismus, but I always tell patients, like, my goal for them is to have what I call like positive pelvic experiences, right? So let's say you and your spouse or your partner are not at a place where penetrative sexual intimacy is possible due to pain, right? There are many other ways you could be intimate with your partner that can lead to positive experiences, which will help sort of ease that emotional angst. And I feel like that's kind of a better way to build on healing than like, I just got to muscle through it and like have sex because we're trying to have a baby or because, because my husband deserves it. As you mentioned earlier, we get told that a lot as women. So I think it's important for us to also help educate our patients that there are other ways to be intimate with your partner. And that oftentimes the more positive pelvic experiences a patient can have, the easier it's going to be for us to get them to a point where penetrative intercourse is tolerable, or more than tolerable, it's enjoyable, right? So that's always a big deal too.
And again, kind of what I was touching on before, it's important for women to understand that if you make yourself push through the pain, you actually do more psychological and physiological damage that actually prolongs the problem. You're not, it might be a short-term fix because, okay, he gets sexual release, great, good for you, but you are doing tremendous long-term damage to your marriage because you are harming yourself and you're a person in that marriage. Oh, sorry, go ahead.
Now, all I was going to add to that too is like, you could compound that too for our patients who we get, like a lot of our patients who you'll talk about this more with vaginismus, but Many of those patients also have had trauma. They've had physical trauma or sexual trauma or birth trauma, or pelvic trauma. They might have had a really negative experience with a pelvic exam at some point. And so I think what you're saying, where they're just pushing through it, that can oftentimes even make that trauma more compound and make it even harder. So yeah.
Mm-hmm. And we've been talking about vaginismus all along. So like, just to clarify, it's the spasm of the pelvic muscles. And it's not voluntary. It's like what we would call a neuromuscular dysfunction. So there's a communication mismatch between the muscle and the brain, and these muscles are spasming outside of a person's control. And so what it does is it literally closes the vaginal opening. So then when you try to push through with anything, a tampon, a finger during a pelvic exam, during intercourse, it's painful. It can be painful. For some women, they don't feel anything. It just feels like they're hitting a brick wall and like nothing can get through. For others, it can be extremely painful. And so like you were saying, the more you do it, the more you reinforce that bad cycle, to where the body is trying to close the vaginal opening, yet you're trying to force it. So it wants to close it even more. And so the way that we can help with that is to start giving some positive pelvic experiences, and we retrain to the pelvic muscles to get control over that area again. And there's a lot of different ways we can do that. One of the most common ways with vaginismus specifically is one, if there is some nerve hypersensitivity to where, if you just touch the skin lightly and it feels like you're getting stabbed there, that's a nerve hypersensitivity. We can retrain that nerve to have a normal sensitization again. And then we work on getting control over those muscles with stimuli, with pressure, with penetration. One of the ways that you can do that is through dilators. And that word can sound pretty intimidating to a lot of people. So dilators, this is an example of one. It is just
it's, to give you a comparison, it's probably about the size of a pinky.
And so we use these as a object to train the muscles on how to regain control over them when there's stimulus at the vaginal opening or internally. And so there's different sizes. These are made up of actually different materials. You can go more rigid or more soft. There's lots and lots of variety about them to reach the goals that we need for the individual person.
And this can be used either by the clinician in the clinic, or the patient can use them at home on their own. Sometimes with vaginismus, like I've even had patients where they don't tolerate internal work in the clinic. And so I just work on release of the external tissues. So like the connective tissues of the abdomen, the glutes, the inner thighs. And then at home, I'll give them dilator work. And so that what that might look like is literally, if this is like their vaginal opening, they'll insert the dilator as far as they can comfortably, and they might just leave it there for a few minutes and work on deep abdominal breathing to kind of help the muscles relax while there is a dilator in there. So it's almost like we're retraining the muscles that it's okay to relax when there's some sort of penetration there, right?
And what does that even mean? What does it mean for a muscle to release and to let go? Because that's often that is a skill set in and of itself, is how do you control your muscle to let go when you tell it to, and how do you tell the muscles to contract when you tell it to? Those are skills that then have to be developed.
That's awesome. So I know we do have obviously some Catholic listeners who are talking about manually inserting an object into the vagina that is not a penis. And probably a lot of people are wondering, how is this not masturbation? So can you just take a second to address that? Because I know that's going to be a question on some people's minds.
Absolutely. Well, I think first go into the definition. So masturbation is self-stimulation for personal pleasure. And so it eliminates your spouse. It is an act of selfishness. It's not for the act of marriage or intercourse or anything like that. And that's not what we're talking about here. This is, as we're using a dilator or a finger or anything like that, a vibrator even, we're using it as a medical tool. So very similar to how if you were to have tight leg muscles and you roll on a foam roller to help massage that out, we can use these devices as medical equipment, not necessarily for pleasure. And when you're using them, anyone who's had pelvic floor therapy can attest to this. There's nothing sexy about this. It is homework. It is exercise. And it's very challenging. It's challenging work. This is something that does take time and commitment and diligence to do. So it can look like it at a glance from the outside, but the intention behind it is vastly different.
Yeah.
And even if we go into, so one of the biggest crossover areas is for masturbation is desensitization. So that's where you have a part of the body that has become hypersensitive to stimuli. So like I was talking about, you lightly touch it, but it feels like you're getting stabbed, or it feels like you're pressing on extremely hard. One of the biggest areas that can occur is at the clitoris. So if you are even near the clitoris and you stimulate it with light touch, it can feel like it's on fire or it's getting stabbed. And so you have to desensitize, you have to retrain that nerve how to appropriately feel the correct sensation. And that is done by touch. Now, there's a specific way we instruct it, and there's a specific way to do it. But at a glance, it can look like masturbation. But again, it is not for the intention of self-pleasure, for eliminating the need for your significant other, your spouse. It's for a medical homework process.
Yeah. And I think what people wonder about with that too is like, oh, well, but it's helping me have intercourse, right? Like, let's say it's somebody who's got severe vaginismus and they want to get pregnant, right? And so they might think, oh, well, I'm using this to help me enjoy intercourse. So is this somehow masturbation? And I would say, like, look at fertility medications, right? Like, there are many different ways where you can assist with fertility. And so you wouldn't look at a fertility medication and be like, oh, well, I shouldn't be taking this because, so it's a medical product, like Jenny said, and we're using it basically to help these patients function normally again and pain-free.
Okay, awesome. Thank you guys for covering that, because I know the answer to that, but it's just helpful to have like a thorough explanation. So just briefly, I know it's kind of interwoven. I think probably the most obvious use for pelvic floor physical therapy is postpartum. And I know like some women just think like, well, I had a C-section, so everything's fine down there. It's like, no, you had a baby sitting on your pelvic floor for 9 months. I don't care how that baby came out. But I'm really interested in the like talking about endometriosis and female infertility. We want to get into male infertility because that was fascinating, but female infertility, is it more of just pain relief, or is there actual benefits to the therapy for the relieving of infertility?
So especially when we're talking about endometriosis, a lot of it is symptom management. So we can try and help manage the whole process a little bit better. And so we in therapy cannot control the endometriosis itself. So that's the endometrial tissue coming outside the uterus and attaching itself, implanting in the abdomen or the pelvic or on the organs. That's what the medications try to control. If surgery treats it and it goes in and actually excises all the endometrial tissue. However, endometriosis is an inflammatory process. And so you're going to get side effects from that process that we can help with. People with endometriosis tend to have more fluid in the abdomen, free fluid in the abdomen and pelvis. We can help with some of that management. There's scar tissue that builds up and myofascial restrictions in response to that chronic inflammation. Typically, when you're in pain, your body is going to tense around the area of pain to kind of protect it as a response. And so we can help mitigate some of that muscle tension, the spasms, the trigger points, as she mentioned before. And then hitting functionally, how is that impacting your life? So a lot of times you'll have kind of sequelae of issues that follow with endometriosis, like you're having bladder problems, bowel problems, painful painful sex, like... And that's where we can get into the function of the bladder and how the muscles are functioning during those processes to get back to as best of a life that can be lived with that kind of diagnosis.
And we often oh, I'm sorry, did you want to add something?
I was just going to add, like, much like we talked about with painful sex, like we're oftentimes speaking to the doctor. So whichever physician is medically managing the endometriosis, we're talking to those doctors consistently, so that again, we can take a collaborative approach, and make sure we're kind of addressing everything. If the physician noticed anything sort of significant in surgery, they might let us know, hey, we had a lot of scar tissue in this portion of the abdomen, really focus a lot on there, or things like that. And so, I think a collaborative approach again is really important there.
That's really good to know that y'all are willing to talk to doctors. I think I totally agree. The collaborative approach is so important. If only our doctors could communicate to each other.
Yeah.
And let's talk about treating the whole person, because one doctor doesn't know every system of the body.
Yeah. Yeah.
So that's really valuable. I also wanted to ask, because something that we try to educate women on when it comes to endometriosis is that a hysterectomy is not a cure for endometriosis. It's a cure for something called adenomyosis or adenomyosis, however you want to pronounce it. But endometriosis can continue to grow. So it's important for a surgeon to remove that. So wouldn't pelvic floor physical therapy still be just as applicable for a woman who does not have a uterus?
Yes.
Absolutely. And sometimes even more so, because one, it's a major abdominal and pelvic surgery. And so you're going to have that scar tissue that develops. And then you also, it's a major surgery. So you're down for 6 weeks, if not longer, depending on how you heal as an individual. And so then you're going to go into, just general weakness, stiffness, that sort of thing. So there's a lot that comes after a major surgery.
Yeah, pressure management is huge. So I think a little known fact about hysterectomies is that if you do not have appropriate therapy after a hysterectomy, it can put you at somewhat increased risk of cervical prolapse. And so that's because there's nothing really holding up the cervix anymore, right? And
You've removed those ligaments.
And so a lot of what we can do post hysterectomy or even post cesarean, any kind of abdominal surgery is pressure management, and kind of reteaching the patient how to manage their abdominal pressure with bowel function, with daily activity, with lifting their kids, with working out, all those sorts of things, so that we can allow the tissue to heal appropriately and reduce that risk of having any further complications.
I just got to be honest. Y'all know I've shared a lot about how I've experienced endometriosis pain for years, and I've had 12 surgeries. I just had a hysterectomy. I was aware pelvic floor physical therapy existed years ago, considered it, but I was nervous because of this internal work that you're talking about. That's the only thing I knew about it. And so I've been very hesitant. I've also been experiencing some more painful intercourse for various reasons. And I've never stepped foot into a pelvic floor physical therapy office. So I'm sharing this because it's a struggle for me too. And I talk about this stuff all the time. It's very hard for me to get myself there. And we had this conversation when we talked, and I now, after talking to you, I know I need it more than ever. So just to hold myself accountable, but I just want y'all to know you're not alone. If these are things that you've struggled with and you haven't been able to say them out loud or admit them to yourselves, I am right there with you. So.
And for you, I know we spoke about this in person, but to normalize it for everybody else, like, it's not like we meet you and 5 minutes later, you're on the exam with your pants down. So we move at the pace that you're most comfortable with. We thoroughly talk through everything, and an internal exam may not be the most appropriate at the first visit. We may not ever need to do an internal exam. There's plenty of things that may be more important. And so pelvic floor therapy, first and foremost, is an individualized plan for every single person. And so there is no cookie cutter. You work through steps 1 through 7, and then you're magically healed at the end. So there's lots of options there.
Yeah.
And shout out also to C-section mamas, because I really appreciate you guys highlighting that. I've had 2 C-sections, and I actually asked somebody, like a doctor, like, would pelvic floor physical therapy be helpful? Nah, you're fine. You just, it's not a big deal. And I'm just like, it's incredible just how low, or just how little we accept for ourselves. So I really appreciate you bringing that up, ladies. Like, C-sections are major abdominal surgery. Major abdominal surgery. Like,
if you ever watch a video of one,
I did recently, and it was jarring.
The amount of tissue that they are having to cut through is, it's a lot. And to think that a woman is going to have, I don't know of a single other surgical procedure that people can have where they're like, okay, you can go home now. You don't need any therapy. You're fine. It's okay. You'll recover in like 6 to 8 weeks and you can go about your life. I don't know. I honestly don't know any other surgical scenario in which that is done. And so the fact that it's not really recommended for women with a cesarean, it blows my mind.
Yeah, and not even not recommended, but like I was told that it wouldn't be valuable.
Yeah.
Right.
Point blank.
And I
Yeah.
have heard, I've read in research, so it takes 9 years for a physician to learn information before it becomes a natural part of their practice. So part of that is just the United States healthcare system as a whole. And so we got to keep learning ourselves, and we got to be the best advocates for ourselves that we can be. So if one physician blows you off, then maybe it's time to look for another physician that can be a better cheerleader for you in your court.
And just a quick PT plug, in the state of Louisiana, we have direct access for at least the evaluation and 30 days and a month's worth of treatment. So if you've gone to even multiple physicians and they refuse to give you a referral, don't worry, you can still come see us. And we don't need a referral. If after the 30 days you're not seeing improvement, that's when we would reach out to whichever physician you'd like us to and say, this is what we've been doing thus far. We think that this patient would still benefit from physical therapy. And can you please give us your sign off, your blessing to keep going?
I'm so glad you mentioned that, because it was not always like that. Usually you would need a prescription from a physician to go to physical therapy. So that's a pretty big deal.
Yeah.
Okay. So we've discussed a good bit about female infertility. I want to switch over to male infertility now, because Dr. Jenny, you and I had a fascinating conversation about this. It really blew my mind. So I just want you to start, like, just go tell us everything that you know about male infertility, because this is a question Emily and I get a lot. We talk so much about female infertility and they're like, what am I supposed to do? My husband's, he's having trouble with his fertility. So just talk to us about that.
Yeah. First of all, male infertility is just under researched. It's underexplored. We don't know a whole lot. I mean, if you even consider historically how the United States healthcare system manages it, we have an OB-GYN. So you have an obstetrician gynecologist, but there is no male equivalent. Like urology takes over some of that, but their specialty is the bladder. So it's just underserved area as a whole that I hope is going to continue to improve. So for men, just like with women, it's not a one size fits all, one problem answer. So physical therapy as a whole may just be one component of it. But for a little background information, we have an area in our body called the Inguinal Canal. So if you think of like the groin, where the groin is.
This is a female pelvis, but the inguinal canal will still be the same.
So if you think of where like the groin is, if you come just above it, you have the inguinal canal here. And there's a lot of really important structures that run through that, including in men, it's the testicular vasculature, so the artery and vein that go to the testes, and the spermatic cord, which includes the vas deferens. So the vas deferens is the tube that connects the testes and the epididymis to the urethra, and it does transport the sperm from the testes and epididymis to the urethra for then ejaculation of the sperm. So with those structures running through the inguinal canal, they can have restriction. So you can have myofascial restriction, you can have muscle tension, because the inguinal canal itself is just an anatomical space, and it's created from the different layers of your abdominal muscles. So between your obliques and your transverse abdominis, then you have this gap, if you will, in between them that we have labeled the inguinal canal in healthcare. So if your muscles are too tense, it can restrict that area and kind of compress those structures that are running through it. If you've had a hernia, it is one of the most common sites for a hernia. It's called an indirect inguinal hernia. 2/3 of all hernias are indirect in this area. And so that itself is a protrusion through this space that is literally compressing the structures that run through it. Can become very painful if it gets too large. And it can even be an emergent situation if it starts to get infected. And then if you've had hernia surgery or any other kind of abdominal pelvic surgery in that area, you can get that scar tissue that can develop post-op. And so all of that can be restricting those structures and just let them be suboptimal. And so like with anything in the fertility world, if you have a couple things that aren't working optimally, together, that may create a really problematic situation, to where if you can address just even a couple of those to improve them, that might be enough then to improve your fertility chances. And so we just may be one piece of the puzzle for men and women, but for men in this circumstance, that could help them.
So obviously it's not a cure-all. Okay. You're not going to snap your fingers and they're going to be able to get pregnant. But would you say that if a couple is having infertility issues, it is worth just for the man to go as well to get an evaluation from a pelvic floor physical therapist?
Absolutely.
Yeah.
And I will tell you, the more times I suspect this in men are your more fit, healthy men. So they're the ones who are working out every day, eating all the right foods. They look physically like they're in great shape. And yet when we go to do our evaluation, we're hitting check mark after check mark of, oh, that's not the way we would like that tissue to be, or this structure isn't quite doing the movement that it should be doing. And so it's, a lot of times those are the ones that are getting overlooked on the medical side of things by the physicians, because on paper their numbers look so great, but then when we do our evaluation on the physical therapy side on functionally how the structure is supposed to be performing, and it's not good.
I'm just speechless how this has been so overlooked for so long. I mean, for women is one thing, but for men, that's a totally a whole nother conversation that we're having. I have one more quick question about male infertility, because you were explaining that not all pelvic floor physical therapists have the experience, would you say, to treat this male infertility. So can you explain, if someone doesn't live close to you, how they would find someone who could do this kind of workup for male to assess male infertility?
Absolutely. Off the bat, I am a huge fan of doctor shopping. I think you should interview every healthcare provider you interact with, including pelvic floor therapy. You got to be comfortable with who you're working with. So pelvic floor therapy as a field is not taught in PT schools in the vast majority of them. So all of this is post doctorate training that we do on our own to get this specialization. So that's number one, is you're looking for either a pelvic health or pelvic floor therapist. Not all pelvic floor therapists do internal work. And if you're going to go after something very specifically, you want someone to have the training to do the internal work. Not that you're going to have it done to you as a patient, but it does speak to that therapist's specialization and how far they have advanced in their specialty and skill set. So you want them to be knowledgeable enough to be able to do internal work. Then beyond that, there's a difference between treating men, women, and children. So you have to ask who they treat. And then beyond that, you have to ask what they feel comfortable treating. So just because they treat men does not mean that they treat male pain or male fertility challenges, and that, I think, is part of the difficulty with our field, is it is so selective as to what the therapist wants to treat or feels comfortable treating. It truly is a phone call to interview the therapist to make sure that they're going to be a good fit for you. And when I have a patient, for example, I've had a move away when we're in the middle of therapy, I am literally on the phone after I look on Google to find a therapist near them, asking the front desk, hey, I need to know if this therapist treats this, this, and this. And those are my questions and the order that I ask the question.
Yeah.
Sorry. That's helpful. I know that this can be like one of those things, because it is so niche, it can be hard to find. And I know that can be intimidating. And I talk to people just about like getting into the psychological therapy, and they're already just like, I don't even know how to get started. So that's really, really helpful. So let's, people might be kind of we've kind of talked about some of the overlaps, certainly with talking about fertility issues, but your business is physical therapy and ours is fertility awareness. And, we totally see how this stuff goes hand in hand. That's easy for us to figure out. This is about holistic health. If you're talking about fertility awareness, you eventually are going to be talking about, your sex life, and then you're talking about pain, and then you're talking about, all this stuff. So it goes hand in hand. With your experience treating so many different women and observing firsthand the impact of mainstream medicine on a very, very intimate level, how do you view fertility awareness and the value of body literacy?
I love this question because I love body literacy. I think body literacy is so important on multiple levels, especially fertility. But what I always tell patients is you are with your body 24/7, 365. You know your body better than any other healthcare professional, than anybody else. You know what it feels like. You know when things are off. You know when things are maybe feeling not normal. And I think the more we can encourage body literacy and body autonomy, the more patients will be better advocates for themselves. And I think, excuse me, I think Jenny feels this way, but for me, like she was saying, we don't necessarily even need an internal evaluation. Excuse me. Take a sip of water. We don't even need an internal evaluation on our first appointment. If I, excuse me, if I can walk away from the first eval, and if nothing else, the patient feels like they were educated on how to understand their body better, then I feel like that was a successful evaluation. So even if I had very little time to actually lay my hands on the patient, if I have been able to educate the patient on what's going on with their body, why they're having that pain, what's normal, what's not normal, other healthcare providers that we might need to get on board to maximize their outcomes. If I can do that for the patient, I feel like I've done my job for the evaluation, because I feel like you can't possibly make decisions about your healthcare unless you fully understand, what's happening. And so I think body literacy for fertility specifically will help people realize that it is oftentimes a multi-clinician, multifactorial approach. And I think it will help them start to seek out other interventions, right? So like maybe previously they were only seeing a fertility specialist. Maybe now they'll see a pelvic health PT. Maybe they might even see acupuncturists. I mean, there are acupuncturists who specialize in helping with fertility. So I certainly think that body literacy is I mean, I could get on this soapbox for, gosh, hours upon hours upon hours.
Us too, we get it.
Yeah. So, I think too, it helps you realize, like, once you really start tracking, I know for me, I feel like I've always been like fairly body literate, but I feel like the older I've gotten, the more I've kind of tried to hone in. And I think more than anything, that's helped me realize sort of that, like, my sleep affects certain things, and like it's all intertwined. Like after I have 2 kids, and my youngest is 6, and when he was about 2, I started having all these weird hormonal things, and I went and got my hormones checked, and I went and saw my OB, and I saw my PCP, and they were like, oh, everything's fine, you're fine. And I knew something was not fine, right? Like I did not feel fine. And so I started realizing that, like, well, yeah, my sleep is terrible and my cortisol levels are through the roof. And that has now affected my thyroid levels, which have also affected my female hormones, which has now affected my menstrual cycle, and so I think the more we can realize how all encompassing it is and how all systems really need to be working together for us to have optimal function, I think the better off patients will be, and the better advocates they will be for themselves.
Mm-hmm.
I am slow on the mute button, man. I love that. No, you're so right. Like that, just, we have no idea the interconnectedness of our physiology and how when one hormone gets thrown off, like your cortisol goes through the roof, what the trickle down effect is on the rest of your hormones and how that affects your daily life. I was talking to a friend recently, and she was talking about how she was like, yeah, I'm just having a really hard time sleeping. And then I'm feeling like so anxious. And I was like, well, yeah, because when you don't sleep, your adrenals don't recharge. So your cortisol levels are really high. And she was like, oh, and she was like, oh, okay, so I'm not crazy. I just need to get some sleep. And I was like, yep, that's it. So it's helpful. So Dr. Jenny, so our final question, we kind of wanted y'all to give your elevator pitch. And I feel like Dr. Emily, you kind of gave just a really good one. So Dr. Jenny, I'm going to throw it over to you. What would be your elevator pitch for fertility awareness?
So, I mean, if you look at women on the lifespan, we spend like 1/3 to 2/3 of our lives with dealing with some sort of menstrual cycle, longer if you even consider yourself postpartum, or I'm sorry, postmenopausal. And so that's a long time of your life to just have a big old fat question mark of, I don't know what's happening in my body. It just kind of does its thing and I'm along for the ride. So just from that standpoint, everyone should have more awareness in this realm. But more so than that, more specifically, we mentioned earlier how like your vaginal tissues, for example, are very reliant on estrogen for their natural health, their plumpness, lubrication, strength of the muscles. And so these hormones affect more than just your ability to get pregnant or to not get pregnant. They affect your vaginal tissues. They affect your urinary system, cardiac system, skin, hair, brain function. And so for your holistic body, it's a really great place to start to understand your body. And then as you become more aware and the more you learn, you'll be more fine-tuned to the adjustments, or when you start to see something not work as optimally as it could, and then you'll be able to address that sooner rather than later before the problem becomes more severe. And then you'll be able to contact places like FAbM where you have access to all of these different resources. And the more we can learn about ourselves, the more control we have of our bodies.
I love it. And we appreciate y'all's support so much, because I know y'all said y'all are a big fan of FAbM, and we're a big fan of y'all. I learned so much today. I feel like I'm catching up for the last 35 years of my life. So we're so happy to get this information out there, and we're just so grateful. Thank you both so much for joining us. Is there anything that we missed that we didn't ask about that you guys want to add?
No, I think, only thing about y'all asked about how to find providers. So the APTA, which is the American Physical Therapy Association website, and another website called Herman and Wallace, which is another organization that certifies for pelvic floor physical therapy. They both have find a provider tools on their homepage. And so you can search by city, you can search by state, and then it at least gives patients a good place to start. They can maybe look at the patient, the clinicians that are in their area, and do some calling to see, like, do you treat this specifically? Do you feel comfortable with a patient with this diagnosis, and so on. And so that, I think, takes some of the stress out of finding a provider in your area.
That is so good to know. I had no idea. So we're going to put all that information in the show notes for everybody listening. Also, know that we have had several people recommend specific physical therapy practices to us that we have placed on our website. So if you go to fambase.org, then resources, external resources, we have a physical therapy tab as well there. So we'll be updating, and I added Dynamix there after I spoke with them. So you can reach them there if you want, but also just check the show notes, and you can also find them on Instagram. But again, we're so grateful to have y'all. Thank y'all so much. And to our listeners, thank you for spending some time with us, and we can't wait till next time.
Yay. Thanks for having us. We had so much fun.
This is awesome. So appreciate it.
Okay, sorry.